I'm Mubashir Pervez, and I'm an interventional neurologist at Cleveland Clinic, Florida. For a change, this talk is not about cerebrovascular disease. Rather, I'm going to highlight an interventional spine procedure as the need is growing for this procedure and more interventionalists are performing it in their practice. I am talking about percutaneous vertebral augmentation. The major causes of vertebral compression fractures include osteoporosis, traumatic falls, and cancerous lesions like multiple myeloma. Compression fractures are more common in women and in individuals with the conditions that affect the strength of the bones. These are some of the risk factors which contribute to worsening of osteoporotic fractures. As osteoporosis progresses, there is evidence of trabecular bone decreasing the end plate strength, causing depression and subsequent compression of the vertebral body. The most common symptoms we see are related to back pain, which leads to limited mobility, tenderness in the spine region at the fracture site, and muscle weakness and spasm. The long-term effect include kyphosis, decreased lung capacity, bladder and bowel problems, and chronic pain. A detailed neurological examination is needed to look at point tenderness of the vertebral body, followed by initial imaging like X-ray, CT scan, and MRI of the spine, which helps diagnosing a vertebral compression fracture. The treatment options are bed rest, physical therapy, bracing, and pain management. However, in situations when conservative management is not enough, percutaneous bone augmentation in a form of kyphoplasty or vertebroplasty should be considered to avoid getting caught up in a progressive downward spiral. Percutaneous vertebral augmentation mainly includes vertebroplasty or kyphoplasty. Both are minimally invasive, and they are done under moderate sedation or general anesthesia, depending on the patient. In vertebroplasty, polymethyl methacrylate, which is a bone cement, is injected through a small needle or trocar in the anterior portion of the vertebral body. And in kyphoplasty, a low-pressure space is created with the help of a balloon, which helps settle down the bone cement in the anterior portion of the vertebral body. Both unipedicular or bipedicular approaches can be used depending on the patient's anatomy. And this is a demonstration of the steps of kyphoplasty. In my practice, I use needle guidance software to guide my way to the anterior portion of the vertebral body. A balloon is used to create a space and which helps the cement to settle down in the anterior portion. And on this image, as you see, there's a trajectory of the trocar extending from the superolateral aspect of the pedicle down to the anterior portion of the vertebral body. This is a 68-year-old woman with L1 vertebral body compression fracture. On MRI, T1 sequence is hypointense, and the L1 vertebral body corresponds to edema on the short T1 inversion recovery sequence, which is a FAD suppression sequence highlighting the edema in the vertebral body corresponding to acuteness of the fracture. Here I used a needle and a drill to advance my the device or the trocar to the anterior aspect of the vertebral body to give enough end-to-end plate support with the bone cement noted in the post-operative cone beam CT scan. And this is a 63-year-old male with history of cancer and recent fall causing compression fracture. You can appreciate the bipedicular approach and the use of balloon. On the post-operative CT scan, you see the uniform distribution of the bone cement in the anterior aspect. And this is a 71-year-old woman with history of osteoporosis, and we can appreciate the T12 compression fracture. And the patient presented with worsening pain, was not improved, and the MRI was suitable for kyphoplasty. And here we can see the needle guidance and the trocar and the kyphoplasty needle extending to the anterior aspect of the vertebral body. And you can see the cement settling down there. I had to adjust the needle with the curved needle approach to get the cement in the right spot in the anterior aspect. And this picture demonstrates the uniform distribution of the cement in another patient. That's the idea about it, like to get the cement from end plate to end plate in the anterior two-thirds of the vertebral body. There are risks and complications associated with this procedure: infection, numbness, nerve damage, bleeding, bone cement migration sometimes to the nearby disc space or venous plexus, which can ultimately cause pulmonary embolism sometimes. So we have to be very meticulous in selection of the patient, bony anatomy, and also fluoroscopy should be done all the time to be making sure that cement is settling down and not migrating anywhere. Thank you.